Pancoast tumor is a classic type of lung cancer situated in the apex of the lung. Here's an example of a Pancoast tumor that can be seen in the right upper lobe of this chest x-ray. These carcinomas are typically non-small cell lung cancers. So why is that? As you might remember, small cell lung cancers tend to be centrally located. You can get Horner syndrome with ipsilateral ptosis, meiosis, and anhidrosis with compression of the cervical sympathetic plexus. Now, what structure is affected if you get pain and weakness in the arm and hand? The brachial plexus. You can also get hoarseness if the right recurrent laryngeal nerve is involved. We mentioned superior vena cava syndrome earlier as a potential complication of lung cancer as part of the sphere mnemonic. This basically occurs when you get obstruction of the superior vena cava. In this chest x-ray, you can see the lung cancer mass compressing the superior vena cava. So what would be the clinical presentation? Since you're blocking venous return from the upper part of the body, you can see facial swelling or plethora, as well as JVD and upper extremity swelling. You can also get shortness of breath, headaches, dizziness, and rarely cerebral edema, aneurysm, or a brain hemorrhage. Here's a picture of a patient with SVC syndrome with facial swelling and with resolve later on in the day. You can see the fullness of the face on the left compared to what his face really looks like. SVC mostly occurs in older folks secondary to bronchogenic carcinoma. If you saw this in younger folks, what would you be thinking? Well, you might think lymphoma or leukemia or possibly something infectious like TB. Thrombosis can also be a cause, secondary to any type of coagulopathy or maybe a central venous foreign body like a catheter, a pacemaker, or a guide wire. This condition is obviously a medical emergency, and treatment choices include steroids, diuretics, endovascular shunt, as well as surgery, radiation, and chemotherapy directed towards the lesion. Anatomically, you can think of infectious pneumonia as lobar, bronchial pneumonia, or interstitial. Lobar pneumonia is characterized by an intra-alveolar exudate that leads to consolidation, potentially of an entire lung. The most common organisms in the outpatient setting are strep pneumo and occasionally Klebsiella. Here's an example of a lobar pneumonia in the right lung. So, what lobe is it in? Obviously, it's not the right lower lobe because you can clearly see the right hemidiaphragm. So, is it right upper or right middle? Well, it's right upper because this whole lower area is where the right middle lobe would be, and it's clear. Here, in fact, is an example of that right middle lobe lobar pneumonia that I showed you all in the respiratory anatomy talk. Now, even though it's in the right lower part of the lung, you can clearly see the right hemidiaphragm. So, bronchial pneumonia is characterized by acute inflammatory infiltrates from bronchioles that extend into adjacent alveoli. Typically, you'll see patchy infiltrates on chest x-ray that involve more than one lobe. Here's a histopath image showing massive amounts of neutrophils infiltrating into the alveolar spaces. The infiltrates can also consolidate, as seen in this gross specimen. These are some of the typical bugs that cause bronchial pneumonia. Let's talk about a few of them. When do you expect to see staph pneumonia? You're typically going to see this as a complication of the flu or a viral pneumonia. You'll also see this in IV drug abusers, hospitalized patients, elderly folks, and folks with chronic lung disease like COPD. Now, where do you find H. flu pneumonia? Usually you'll see it in babies and young children. You can also see it in adults with COPD and other chronic lung disease. Now, what about Klebsiella? Think diabetics, alcoholics, and the elderly. Basically, immunocompromised people. Remember, of course, the red currant jelly sputum that you might have read about. I'd also throw in Moraxella catarrhalis, which you can see in the elderly and patients with COPD. Finally, it's worth mentioning a few specific bronchial pneumonia types like aspiration pneumonia. What type of bugs would you expect to find in aspiration pneumonia? Since it's aspiration, you'll probably see gram-positive or gram-negative anaerobes from the mouth. The pneumonia will also be located in the more dependent segments of the lung. Then there's ventilator-associated pneumonia, or VAP, which is something we often see in intubated patients. This is a bronchopneumonia frequently caused by staph, as I mentioned, and also Pseudomonas aeruginosa. When you have a patient with a non-productive cough, with fever and shortness of breath, you may think about interstitial or atypical pneumonia, and it's commonly associated with viruses, Mycoplasma, Legionella, and chlamydia. Mycoplasma in particular tends to occur in what type of populations? Well, you'll typically see it in older children and young adults. On chest x-ray, you tend to see a diffuse patchy inflammation localized to the interstitial areas at the alveolar walls. You often hear this pneumonia referred to as a walking pneumonia. So why is it called a walking pneumonia? That's because it tends to have a more indolent course than other types of pneumonia. Now, getting back to the bugs, Legionella is a gram-negative rod that's associated with what? Well, it's classically associated with aerosol from contaminated water sources, including cooling towers and large air conditioning systems. It causes, of course, Legionnaire's disease. What is the mild flu-like form called? It's called Pontiac fever. Legionnaires can be deadly if not treated with a macrolide or quinolone. Here's a silver stain of lung tissue in someone with fatal Legionnaire's disease. The dark specks are all Legionella pneumophila bacteria. Now, Chlamydophila pneumoniae is a common cause of community-acquired pneumonia. But what if I told you that a patient working at a pet store comes to you with signs of atypical pneumonia? Well, you would probably think of psittacosis, caused by Chlamydophila psittaci. Psittacosis is also known as parrot fever, secondary to transmission from pet birds like parrots, parakeets, and cockatiels. Lung abscesses, as you can see in this chest CT and a gross path over here, are most often due to aspiration of mouth anaerobes. You can also get it from bronchial obstruction, such as lung cancer. In general, these folks are sick, malnourished, older, or debilitated in some way. The typical bugs are anaerobes, like Bacteroides, Fusobacterium, and Peptostreptococcus. So how would you treat this infection? Well, they typically respond to clindamycin. Aerobic bacteria like staph, strep pyogenes, and Klebsiella can also do this, especially in what setting? That would be a hospitalized patient with aspiration pneumonia. And here, in addition to the clindamycin, you would also add a cephalosporin or ampicillin plus sulbactam. Finally, don't forget that fungi like Aspergillus and Candida can also do this as well, as can parasites like Entamoeba histolytica. Hypersensitive pneumonitis is a delayed hypersensitivity reaction to some environmental exposures such as aerosolized mold or dropping, leading to an IgG type 3 hypersensitivity and a CD8 positive lymphocyte type 4 hypersensitivity response in the alveoli. This is not a type 1 reaction like in allergic asthma. And also unlike asthma, the inflammation, as you can see here, is more centered in the alveoli as opposed to the bronchi. Symptoms usually show up 4 to 6 hours after exposure, and you get dyspnea, cough, chest tightness, headache, and a fever. You can also see bibasilar dry rales and decreased diffusion capacity, or DLCO. If you get the chest x-ray, it may look a bit like atypical pneumonia or interstitial lung disease. In farmers' lungs, what's the exposure? Well, it's usually secondary to thermophilic actinomyces bacteria, and occasionally Aspergillus fungi in moldy hay and compost. What about bird exposure? Well, this is called bird breeders or bird fancier's lung. This is due to exposure to avian proteins in the dried aerosolized bird droppings. Keep in mind, this is not psittacosis where you have a true bacterial pneumonia. There are many other work exposure conditions related to hypersensitivity pneumonitis, like malt worker's lung, cheese worker's lung, but farmer's lung and bird breeder's lung are the most common and most likely tested. You can treat these patients with steroids, but the main treatment strategy is antigen avoidance. Pleural effusions are generally classified as transudative or exudative depending on the underlying process causing them. Transudates have a low protein content, or a serum to fluid protein ratio of less than 0.5, and a serum to fluid LDH ratio of less than 0.6 when you examine the pleural fluid. What's the physiologic mechanism for transudative pleural effusions? They happen when either the transcapillary pressure gradient is increased or the serum protein content, and thus the oncotic pressure, is decreased, such as in congestive heart failure, nephrotic syndrome, and hepatic cirrhosis. You can go back to the capillary fluid exchange fact on page 265 for a quick review of Starling forces. Exudative effusions, on the other hand, have a higher protein content, with a serum to fluid protein ratio greater than 0.5 and a serum to fluid LDH ratio greater than 0.6. What drives exudative pulmonary effusions? They occur as a result of processes that affect the vascular or capillary permeability, such as malignancy, pneumonia, and collagen vascular disease. Exudative effusions typically need to be drained due to their increased risk of infection and empyema formation. One other type of exudative effusion worth mentioning is lymphatic effusion or chylothorax. This is typically seen when the thoracic duct is damaged from trauma, such as during cardiothoracic surgery or blocked by malignancy. When you tap the effusion, you typically get a milky white fluid that's high in triglycerides. As we discussed earlier on page 557, pneumothorax can present with classic absent breath sounds, hyperresonance, and decreased fremitus. Patients may also have some chest pain and shortness of breath. Now, when we talk about spontaneous pneumothorax, it's worth breaking it down a bit. Primary spontaneous pneumothorax typically occurs in tall, thin, young males who have these apical blebs that pop but who are otherwise healthy. Well, no one is sure, but it's thought to be related to increased shear forces in the apex during respiration. There are also some cases of familial pneumothorax, especially with Marfan syndrome, Ehlers-Danlos syndrome, and homocystinuria. You can also have secondary spontaneous pneumothorax, which can occur with a variety of different lung diseases. So what would be the top culprit on this list? COPD with emphysema accounts for 70% of these cases. Other causes include severe asthma, cystic fibrosis, pneumonia, interstitial lung disease, connective tissue disease in the lung, and lung cancer. Patients here have more severe symptoms and possible hypoxia because their other lung can't compensate. Another type includes traumatic or iatrogenic pneumothorax. You can probably guess what's going on here. The causes here include any trauma or injury to the chest, like from a car accident or a knife wound. Now, how can you as the doctor or a future doctor also cause a pneumothorax? It can happen when you try to place a central line, biopsy the lung, or put the patient on mechanical ventilation. As we mentioned earlier, tension pneumothorax is one of the few respiratory emergencies where you often have to treat the patient before they get to the emergency room, much less get a chest x-ray. This usually starts as a traumatic or a iatrogenic pneumothorax where the air enters the pleural cavity but can't exit because of a one-way valve mechanism. When too much air gets trapped, it pushes the mediastinal structures like the trachea to the other side, as you can see here. These patients can present with severe respiratory distress that evolve to hypoxia, hypotension, and cardiovascular collapse. If the patient is in severe distress or looks unstable, what would you do next? You have to do a needle decompression immediately, even before you can confirm the diagnosis. So if they ask you on the boards, reach for the needle first, then get the chest x-ray later. Alright, we're done.